can be a part of that as well. So, Dr. Alfgeir Kristjansson.
Good evening. Nice to see all of you, and thank you, Andrew, and thanks to Katie and the Prevention Coalition here for putting this together and having me. I'd like to acknowledge a couple people before I start my talk. Here is Tyler Healy from U360 in Mozilla, who has sort of been one of my longest collaborators here. We've been working together for the last 5 years. And Ms. Amy Gorn from the Matsu Health Foundation. My background of this gathering, you know, why am I here? Why is this Icelandic guy up here in Alaska giving a presentation about something that works in West Virginia? Well, basically, I've been working with the Icelandic Prevention Model since I was a student in the early 2000s. And I was working at the Icelandic Center for Social Research and Analysis at the time. And they had this sort of relatively loose system of doing prevention. I had been growing up in sociology and sort of more theoretical sciences, but I always felt like the applied focus was missing. There's something, what do we actually do with people, you know? And so I immigrated over to public health and started working with the center on this approach, which was largely about gathering data, working with local community groups, understanding local preferences, not just some kind of global averages and publishing them in academic journals, and then working with local groups such as these, people from local government, national government, and all the unit, to try to implement changes that were locally relevant. So I gave probably hundreds, if not thousands, of presentations of this nature in schools, very often in schools, local community halls, with parents and with others. And then I did the first evaluation of the model in Iceland, using both the survey data and other mixed types of data before I moved to the States in 2010. So since I've been here, I've been a professor at West Virginia University since 2012. We were in New York City for the first 2 years, and then we moved out to West Virginia. And we've been doing this work over there with some colleagues. Planet Youth, the organization that's behind or supporting the work here in Seward, came about a little bit later, but grew out of this same kind of sphere. And I've stayed doing work on this, on the model, both on the academic side and the practical side for all this time, probably for a little over 20 years now. And this is exactly what I love to do. So what I'm going to try to do today is to give you a little bit of a glimpse into what is this thing called the Icelandic Prevention Model. Why is that any different from all the typical approaches to prevention? I'm going to try to keep this relatively basic so that we are all sort of in agreement with where we want to move this. This is a collaborative tool. It's not an academic program. It's really a collaborative tool. And in such, I'm going to be a little critical of the way that I think that prevention, or I think that the sort of challenges of prevention are in the usual prevention approaches. And I'm going to show you some data. I'm going to show you some trend data from Iceland, from West Virginia, and from other places. And of course, we can take any question people are interested in. So at the moment, I'm a professor at West Virginia University. I'm also a PI at something called the West Virginia Prevention Research Center, which is a CDC-funded center. We do this kind of thing, what we call community engagement, where we work with communities in doing prevention or health promotion work. We work with state government, we work with local governments. And similar to Alaska, West Virginia is largely rural and has lots of local communities and counties where people live locally and they need much more locally tailored solutions. And than commonly is the case. I maintained my relationship with Planet Youth that grew out of the Icelandic Center for Social Research and Analysis, where I used to work. And although I'm not here on their behalf, I'm actually here as on an invitation from the Matsu Health Foundation. I continue to work with Gwen. So let me just talk a little bit about prevention first, or the nature of prevention. So prevention generally is divided into 3 levels: primary, secondary, and tertiary prevention. Primary prevention is the prevention of the onset. So we're trying to prevent something from starting in the first place. And typical approach to primary prevention that we are most of us are used to with regards to substance use and kids is what we call instructional programs. This idea that we can teach them that drugs are bad, and then if they find themselves in challenging circumstances, they're going to learn not to use them. Okay? This has been the prevalent, most current paradigm in prevention, primary prevention for the longest of time. And I'm just going to say it out loud, it does not work. It does not work. Kids know that drugs are bad. Now, almost all smokers also know that smoking is bad, but they keep smoking. So knowing something and actually acting on it are 2 different things. And we know that from lots of different studies that if people actually would simply do what they know, life would be pretty simple. We wouldn't have the opioid crisis. We wouldn't have the obesity crisis. We wouldn't have all kinds of other crises because people would basically act on their knowledge. Secondary prevention is typical behavior change programs. That is, we have some kind of risky behavior happening. We're trying to divert people into other ways of behaving. The most common approach to secondary prevention is something like, for example, smoking cessation programs. People smoke, they're not yet really sick from it, and they learn to divert that. That is, compared to primary prevention, something that has much greater resources. You have to basically work with every single individual, and therefore is much more costly and more difficult because oftentimes people have repeated attempts and they fail repeatedly. Tertiary prevention is basically our hospital system, the treatment system, where we try to treat people that are really, really sick or direly ill. Now, in the current scenario, we spend 90% plus of all our healthcare dollars on tertiary care. Basically trying to mitigate life-threatening circumstances. People in hospitals, people in treatment centers, and so on and so forth. Now, oftentimes, with prevention, the sort of historical approach has been that we use short-term and predetermined programs in primary prevention. In tertiary care, where we spend almost all our dollars in this situation, we're basically prolonging life as long as we can. But in terms of policy for drug use prevention, tertiary care is probably the most expensive and least effective approach, because behind each person that comes to drug treatment is a long pathway of challenges that has been very costly for society. Not just that individual, all the family breakdown, all the challenges with family relationships, the time out of work, and so on and so forth. We know that one of the best returns on investment is through primary prevention, but our population policies tend to really gravitate towards tertiary care. So back to the primary prevention systems, the way that it has worked. We have oftentimes individually focused programs, so we try to teach kids that drugs are bad. We remove social context out of these systems. Now, what does that mean? Well, it basically means that not all kids are under the same risk profile. Do you follow me? Many kids are simply born into very challenging circumstances. So if we are saying to them, well, you just have to learn how to say no when you're in challenging circumstances, we're basically saying, I'm sorry that you grew up in very difficult background. You just have to learn how to navigate life yourself. Community involvement is usually non-relevant or very limited in typical instructional programs. And the funding lines for typical primary prevention are short-term. So we pay for educational programs to teach kids that drugs are bad. Okay? Next year, we'll just do that again. We'll pay again for some kind of program to teach kids that drugs are bad. And then we tend to do that as a matter of routine, annually, just renewed. We also tend to throw the programs at the schools. So we tend to say to the schools, well, here's this curriculum, you have to run this. This is now a local mandate. And we check a box and say, prevention done this year. Thank you very much. Let's move on to the next thing. Most places have no idea whether this is working or not. So not only is it a matter of routine program, it's usually not evaluated. So nobody knows whether it's working. It's basically a reference back to Nancy Reagan's Just Say No campaign. And that was made a lot of fun of because we know that doesn't work either. So in primary prevention generally, we need to kind of upgrade our thinking. We need to go beyond the individual level education and target communities and subgroups within those communities for what we call contextually relevant and long-term approaches. So what I want to do now, I want to try to explain why this is much more viable as an approach, as opposed to working in these sort of routinely, individually based approaches. The Icelandic prevention model is a primary prevention approach. And not only is it a primary prevention approach, it's a collaborative. What that means is that there are certain things that the authors of the model and the people that work in research and evaluation like me can do. But there's also a number of things that I tend not to. And that is, those are the things that local communities have to take ownership over. The second thing is that this idea that we can go into communities and just start dictating what people do and start telling them what to do has never worked. Nobody likes to be told what to do. So this idea that some kind of expert with background in prevention walks into communities, tells people, you do that, you do this, and I'm going to do my measurement before and after, and then we're just going to say hooray and find a difference and leave, has never been long-term viable. So it's a collaborative and it's contextually relevant. What that means is that we have to take account of different contexts, different resources, different priorities, preferences, and so on. So why primary prevention? Well, first of all, we know, and we have known for a long time, that early initiation is by far most likely to escalate into serious problems. So in other words, it makes perfect sense to try to delay the onset of everything, not just of the strong stuff, but all drugs, including tobacco, alcohol, cannabis, and so on. The drug that kills most people and causes the most damage to society is alcohol. Alcohol takes more lives and kills more people and causes more damage and costs more for society than all other drugs combined. So that should be our top priority before we start focusing on fentanyl or heroin or other opioids. Family and community breakdown can largely be prevented if we work upstream. Primary prevention is upstream prevention. I told her to go with it, it's okay. I actually got tested just to make sure. The other thing is that when we look at the kids that initiate early, and we have done this in 30 plus countries over a long period of time, they tend to share a common profile. Our typical funding lines, typical approaches to prevention are monotonically focused typically on one or two outcomes. But the kids that start to drink early and start to smoke early or start to do other things early are also the kids that are likely to have risky sex, drop out of school, be in trouble at home. It's all the same group, okay? So putting a label on them, oh, you're using drugs now, you gotta do something about this. It actually takes us back to this notion that, well, actually, this kid was born into circumstances where the cards were stacked against them from the start. And only with local community approaches can we actually work with that, as opposed to taking some kind of global average, which tends to be the common way, and then working with predetermined programs. And that's what a collaborative is much more about. So what Seward is now doing with Planet Youth is an implementation of the Icelandic prevention model, which is basically a local cooperative. If we build local capacity and work to empower our own community to take ownership of these issues, we will have much more continuity. We'll have much more odds of real sustainability of our work, and therefore much better odds of really making a change in our community. There are numerous return on investment studies. So return on investment studies are this game of putting assumptions together with costs in and costs out. And it's sort of a kind of a grayish area, but many return on investment studies show that you have great return on investment in primary prevention. So in other words, we need to shift our modeling focus from 90% plus in tertiary care. And I want to underline this. Drug treatment is absolutely necessary. It's absolutely necessary to offer drug treatment when that is warranted. But we don't have to wait and do nothing until people need to go to drug treatment. Then we are choosing the most expensive, least effective approach to prevention there is. So we can do plenty of things before. And that will yield a much better return on investment cost. So let me give you a sort of a hypothetical example. This is still not very hypothetical. This is actually something we do all the time. So if we sample this profile of two kids, one is on the left, lives in a deprived area with relatively high crime rates. Parents separated, mom works 2 jobs to make ends meet. Attends a chronically underperforming and underfunded school. Peers commonly subject to substance abuse at home, and has limited opportunities for participation in organized recreational and extracurricular activities at school and in the community. Kid number 2 lives in a middle-class area with low crime rates. Parents are cohabitating, both full-time working professionals. Attends an average performing and average funded school. Peers unlikely to be subject to substance abuse at home, and has opportunities for participation in a variety of organized recreational and extracurricular activities. If I ask you which one is more likely to escalate and do drug use early, almost everybody would say youth number. The point of the story is that there is nothing in this description that is about personality. There's nothing about individual choices. There's nothing about that this is an individual that just wants to become a drug user, and in fact, no kid wants to become a drug user. Everything in here is about the social context of their lives, where they are from, what kind of background they come from, what kind of support system they are likely to have. That is truly where we should be focusing our efforts. So the Icelandic model really isn't about individuals. It's about building communities. And it's not even about drugs. It's about building, strengthening protective factors and driving down risk factors at the local level. It seems pretty common sense, you know. Some assumptions based on what we were just saying. A substance use initiation risk, that is for, kids that are most likely to be at risk, that is not randomly distributed in the population. It's not even close. If you plot on a graph where is drug use most likely to happen with kids, it's the same pockets, the same areas, the same places that produce most of the new users. So it's not bad kids making bad choices. These are kids that oftentimes grow up in very challenging circumstances where there's very little for them in their environment. In West Virginia, where I live, there are some counties where half the kids grow up without their parents. 50% of the kids. In most of these places, there's absolutely nothing for them to do outside of school. So they go to school, and the school is not only their primary source of nutrition, that's where they get to eat, it's also almost their only place for any kind of social stimuli. So they go home after school into nothingness, and then we are surprised that these are kids that are most likely to begin risk behavior early. This is like a manufacturing system. We are producing new problems all the time through this grinder that we call society. Behavior change is notoriously difficult to accomplish. what that means, we should focus on primary prevention. Let's stop just doing something when the problems have already began. We know plenty about risk and protective factors for substance use onset and progression. Why don't we work with those factors as opposed to just doing something when problems have already begun? And third, and this is difficult in many respects, in substance use prevention, there are no quick fixes or simple solutions. So we should focus on community capacity building as opposed to focusing on short-term simple solutions. Now I know that our system is not geared towards this as a path to solution. We have this system that really funds short-term programs to tackle large-scale problems. And it's the grant system. So we have this grants, programs, hamster wheel that everybody runs on. The outcome is determined largely by who gives out the grants. Whether that works into the future, whether there is sustainability of the work or not, is really not baked in the cake. So if we are to create anything that looks like a long-term sustained effort in prevention, we need to think more than a single grant cycle. And that's where the community building piece comes into play. So the Icelandic model is not a program. It's a process structure to form and maintain cooperative partnerships. And it's an acknowledgement that no program is going to change communities for the long run. Communities need time and effort and local leadership to take ownership of issues like this. Everything we do is data driven. In other words, we do take a measure every year, just like stepping on a scale, which is our way of saying, okay, what are our directions? Where are these priorities that we want to make? And then we make decisions based on those. Working with this data, with the Seward coalition, prevention coalition, is what people like I will do. Collaboration is the central feature of the model. So in other words, it's not a program where Planet Youth or I or somebody else comes in here and tell everybody what to do. It's a collaborative where we have certain things to contribute, but they will not yield any results in the absence of local commitment. So that's why the coalition is an absolute key entity. I don't know if you see this very well, but this is supposed to show the major ecological domains of data collection and risk and protection factors. So the ideas behind the core theoretical idea behind the Icelandic prevention model is that the individual is a product of four major domains. Those are parents and family, the peer group, the school environment, and the leisure time. The risk and protective factor measures in the surveys behind the model, they are all from those major domains. This is then analyzed at the local school community level and at the, well, we can call it county, municipality, or area. I mean, Seward is small enough to have a single high school, correct? So that would be different. And or the state. In the Icelandic system, this would be nation, municipality, local community. In West Virginia, where I live, this would be state, county, local community. I mean, it's the same idea. It's just different names for the same idea. The key thing is you have very high response rates data for every single school community because we want to be able to distinguish between communities. Because one community is very likely experiencing something that another is not experiencing. So if we are not able to differentiate between school communities, we're not as likely to be successful in our prioritization, funding acquisition, and so on and so forth. So that's key. The model is then implemented through what we call the 10 steps to implementation. And let me just take a moment to try to explain these. Many of you may have seen this, but for those that haven't, let me just walk us through this. The idea here is that we have an annual sequence of 10 steps. So every year we should work through the 10 steps. The first step is about identifying a local coalition, developing that coalition in terms of capacity. Now, thankfully, that coalition is already here in Seward, and it's a very solid coalition. The second step is to fund the local coalition. In other words, we need to stop assuming that primary prevention should only be done by volunteers in their free time with their left hand. You know, I mean, people have jobs, people have families, people have stuff to do. So unfortunately, one of the reasons why primary prevention is so poorly funded is that we have this old assumption that primary prevention is something soft and easy and simple to do, and as a result, can be done by volunteers solely. My argument is, and our argument is, that primary prevention should be adequately funded. It just should be fully funded, just like tertiary care is fully funded. I mean, I wouldn't want to go to a hospital that would be run solely by volunteers. So I'm just saying that, you know, the idea that you have primary prevention that is just done by people that are sort of there because they may be interested or may not is totally different from having people directly being paid to do primary prevention. The level of commitment is totally different. So if our coalition is well intact and it's suitably funded, we really want to preparing our community for data collection. So in this step, step 3, we go out and we prepare our community about data collection taking place within the school. This is can be done in various different ways, but having a conversation with our local community members, other parents, the school officials, and people that work in this area to make sure everybody's on the same page is really critical. In step 4, we collect this data in a very structured process typically in the schools. Our baseline criteria for survey return is 80% response rate or higher. And there are many reasons behind that, but one of them is simply practical. It's very hard to sell to people that anything lower than that is truly representative of that individual school. From everywhere I've been, everywhere I've done this work, if you have low response rates between different school communities, people are not going to believe the data. So they're going to say, well, I don't think this is right. On the other hand, if you have collective data for several schools and the data is bad, then they're going to say, I don't think these are our kids. These are probably kids in this other school across the river that have got some more problems over there. If the kid is good, they're going to say, oh yeah, great, we're doing excellent, you know. So we really want to be sure that the data is staring us in the face. We want to be sure that we know that what our findings are truly representing our kids. And this helps us with prioritizing, because prioritizing intervention work should be based on data. In step 5, after we've collected the data, we begin planning dissemination. Dissemination where we send the data in all kinds of forms and ways to different people. We have meetings like this. We have QR codes and social media campaigns and for all kinds of ways to demonstrate and show the data to people. And that's what we plan in step 5. In step 6, we execute that dissemination. And in step 7, we garner what we call feedback from the community about the data pieces. This is where we start preparing goals and other organized responses to the findings. Now, my experience has been that when whatever the data will show, most people will already be aware of this. You know, if our surveys would show something totally different than you would expect from your area, there's probably something wrong with our surveys. Usually, we are simply demonstrating what you already know, and that has been the universal case with those studies for as long as I can remember. But step 7 is an important sort of process in terms of taking feedback from the community and deciding collectively with the coalition, what are the things that we really want to work on? What do we believe are the big issues that are truly important? And oftentimes when the data is, you know, it's lots of variables and it's lots of different findings, our focus is, well, just pick 2 or 3 things to work on. You'll do this another cycle a year from now. Don't worry about everything being perfect at this point in time. In step 8, we do what we call policy and practice alignment. So what does that mean? Let me give you an example. In most places, there are multiple layers of the same kind of service. And oftentimes there may be many groups doing very similar things. So instead of us enacting one more intervention that already is in place, how about we can work with people that are already doing it, such as through the policy and practice alignment. When I came to West Virginia, as an example, I was within a few weeks, I was working in the southernmost county in the state called McDowell County. Morgantown, where West Virginia University is located, is in the far northern part of the state on the Pennsylvania border. Generally, the state becomes more rural and more natural abstraction dependent the further south we go. McDowell County is the southernmost county in the state. It's the poorest county in West Virginia, and it's one of the poorest counties in the nation. At the time, it had about 19,000 inhabitants. That's the population of the county. When we were working there on a project related to this one, we did a policy and practice alignment, and we decided to figure out, okay, well, how many groups of different entities are doing intervention work in this county? And there were 120 organizations, 120 organizations doing some kind of fiddling in the community in a county of 19,000 people. You can just imagine how much overlap there probably is between them and how much really waste there is in a system that works like that. Because there isn't any incentive in the short-term hamster wheel of grants programs for people to truly work together. So as a result, we came to realize that if we are going to be successful, we really need to pull people to the table instead of pushing them away from it. Once we have done these first 8 steps, we make a decision about intervention work. And interventions can be all kinds. They don't have to be something really huge or expensive or firework looking every single time. Many places don't have any funding to do interventions. So if they don't, then we simply have to find something that isn't very expensive, but they still be very effective to do. One of the things they did in Iceland, as an example, they stopped allowing kids to be drunk in school dances. Big deal, man. Didn't cost anything. It was just a mutual decision. And on the other end of that decision was that we're going to call your home if you show up intoxicated. This was not the case. In the mid to late 90s, it was very normal to be in 10th grade to show up drunk to school dances. Not being drunk, but having late, actually. So, these are kind of things that are, definitely they are interventions by nature, but they don't have to cost anything. So interventions don't have to be something we pay somebody else to do and is necessarily very expensive. It all depends on local context. So this is sort of the way the model works. And let me now give you a few examples of how this has shown to be or some results over time, and then we can just have a bit of a conversation. So in Iceland, when this work started in 1998, 42% of our 10th graders have been drunk in the last 30 days. 23% were daily tobacco smokers, and 17% had used cannabis substances. I understand that the cannabis numbers are quite a bit higher here in Seward than they were in Iceland at the time. Today, these numbers are about 6, 6, and 1. This is from 2020, and I believe that they're very similar today. Now, there are 2 sides to this story. There is the period of reduction, and there's the period of maintenance. This is important. It took us about 15 years to have this mass reduction. 15 years. Nobody will fund a program for 15 years. So it needs to be something that is consistent and baked in the cake. And you can imagine these numbers every year are new. There's new kids behind the numbers every year. It's a new group of 10th graders every single year. So you can imagine if I'm in 10th grade in 1998 compared to being in 10th grade in 2015, those are 2 totally different worlds. Being a kid in 10th grade here, substance use is a very normal thing to do. Everybody's doing it. Being a kid here in 10th grade, nobody's doing it. So that's the difference. The environments are different. They are totally different. So the sustainability, which is sort of from 2012 onwards, is I think also equally remarkable. Because now we have multiple generations of kids, or multiple cohorts of kids, birth cohorts of kids, that have not grown up with this situation as they did before. We've done all kinds of studies, and I'm not going to bore you with any boring statistical details, but one of the things that we have emphasized a lot is that for most kids, there isn't one thing that is the big thing. So oftentimes when we work with funders, they say, so what's the problem? What's the one thing that you really want to work with? Well, the right answer is, well, it's actually not one thing. There are numerous things, but we have to think about them collectively. Like I said, there isn't one group in smoking, and another group in drinking, and the third group in violence, and the fourth group in sexual risk-taking, and so it's all the same group, So we have to work with building those kids up. And we did a study where we looked at multiple risk and protective factors in all the 4 domains. Remember this figure here, the 4 domains, they include multiple risk and protective factors. And we found in this study that they are all important. They all work collectively. There isn't one that is boosting all the other ones out. It's lots of different things. Basically, having a healthy home environment where you're well supported, having friends that you trust and enjoy hanging out with that are not using drugs, being able to be happy at school. You don't have to be a super student, but just okay being at school. School is the kid's work site. What happens if I'm unhappy at school? What happens if I'm being bullied at school? What happens if kids are not being nice to me at school? Well, we can ask ourselves, what happens if I am at work and people are not nice to me? I'll probably either find a way to get rid of that job and go somewhere else, or I'll find a way to rectify that situation. Now, the kids don't often have that option. They're kind of stuck where they are. And if kids have something to do, something productive, pro-social, character building, and positive for themselves in their leisure time, a kid with that kind of profile has very little incentive to begin using drugs early. So the idea is, of course, let's try to get as close to building that profile as possible. Now, the first question after this is always, but what about the kids that come from homes where there is no support? Well, then we have to build the support, or try to build the support in different ways. For example, through the schools, or through leisure time programs. That's where we can help them find good support if they're not getting it at home. I know that's not easy either, but this is one way to think about that. This is actually from my doctoral study, from my dissertation study, which was published in 2010. And we did an assessment of substance use and parental monitoring and leisure time activities over a 12-year period in Iceland. Iceland is small and isolated, but we separated the communities that have been working with this approach and the communities that have not, and we found a great deal of difference. And you can imagine, in a country like that, where people tend to know one another and they sort of look like each other and they're very similar in terms of social background, there will be a lot of spillover effect. In other words, if one community is doing something, chances are that other communities are doing it too. Even in that environment, we were able to find this difference. So clearly that was working well. And lastly from Iceland, and this is, I find this quite fascinating. These are trend lines for enrollment proportion of the population of young men. This is an Icelandic, sorry, it's a picture. So KK stands for young men, young males, 20-year-olds and younger. This is a proportion of birth cohorts that go to drug treatment. For the 1982 birth cohort, they were 20-year-olds in 2002. Birth cohort basically just means the year you were born, right? So 1982 birth cohort were 20-year-olds in 2002. 5.7% of them came to drug treatment. The 1995 birth cohort, they were 20-year-olds in 2015. 2.7% of them came to drug treatment. Now remember, the Icelandic prevention model is not about drug treatment. But because we have delayed the onset of use in the population by this much, there is much less need for drug treatment. You follow me? And because there's much less need for drug treatment, we are spending our money on community building activities for our kids, as opposed to spending them on the most expensive, least effective approach to prevention, which is drug treatment. So again, we have to have drug treatment available for people that need it. But if our population policy to combat drug use is to do nothing and just offer drug treatment, we're making very bad choices and not fiscally very responsible either. So this is from actually an annual report of the largest treatment center in Reykjavik. So, you know, there's no question that these things go hand in hand. You better work on primary prevention, you have less need for drug treatment, and the money can be spent on something else. In the city of Reykjavik, just as an example, they're now spending about 7% of their revenue on organized leisure time programs, which they probably were paying a lot for into drug treatment before. So let me give you a few examples of what we've been doing in this country. So we're working with a group in Frankfurt in Kentucky, which is, I don't know if you know Kentucky, but it's a small city in Kentucky between, sort of west, between Lexington and Louisville. It's actually the state seat, but it's a small, town or city. And they focus largely on offering leisure time programs. So the idea were, can we create a system where we offer free leisure time programs through this thing called where is the thing? Well, it's not up here. So they offer this voucher system for leisure time programs for kids that don't have access to any program. And the question was, can we actually increase participation in arts and sports and things like that for kids that do not have those options if we just pay for them, if we just cover them, okay? Turns out that in the Yes card, this voucher is called the Yes card group, participation in out-of-school activities twice the legal board increased from 18% to 32.5% over only a 1 year period. And participation in organized sports 3 times per week or more increased from 41% to 57% over only 1 year period. Participation in the comparison schools that didn't have any of these funding didn't really change. So it's possible to use this sort of routine system, which is actually taken from Reykjavik City in Iceland, in what they call the leisure time card, which is to make sure that kids have access to organized activities. And this is an investment. This is an investment for maybe the next 5 to 10 years. Let me show you a few findings from West Virginia just before we wrap this up. So this is probably a little hard to see. So in my home state, we have funding from the CDC to do this work in 2 counties. Counties collectively of about 60,000 people. The Blue County has done a lot of good work. They have a very high-level functioning prevention coalition. They've been really solid in terms of using the data to apply for further funding. They've got all kinds of activities and programs going, and we track this progress really, really carefully. The other county, the Orange County, has not done as well. There are a lot of struggles in terms of getting their legwork going. The coalition is not really functioning, and they really are. In 2020 and 21, we had this universal intervention. What was the intervention? COVID. COVID came around. I probably don't have to explain to anybody what COVID is. Both go down. Kids are not in school, there's hybrid formats, there's state closures, there's all kinds of fighting about what they should be closed or not closed or so on and so forth. And then in 21, we start to relieve, vaccines come in, and in 22, everybody's back in school. So the county that's been doing a lot of work, they have maintained their low status now, about 10%. The county that hasn't been doing almost any work, they are back to their baseline almost. So in other words, the universal intervention of COVID created a downstream trend for both counties but only the county that really has been doing the background work has maintained their good status, and the other one has not. And the same goes for e-cigarettes. You have this downstream plateau, and then up again by county 2, but continues downstream by county 1. The same for drunkenness, down, plateau, up, down. Same pattern. And even asking them whether they had had a drink of alcohol before the age of 13, which is sort of like a prevention type of measure, the same deal. So in other words, even though these are 4 questions about different things, the trend lines are all the same. This is exactly why primary prevention is holistic community building. And it's not about the outcome, it's about what you do with our kids. And finally, I just want to show you something about this difference between individual schools. So I have Fayette County in my home state, and these are trends for e-cigarette use in middle schoolers at the county level for the county, and then these are high schoolers, and no, these are high schoolers. County and the 4 schools in the county. So this is the county, 22 to 15. Okay, that's a healthy reduction. But if we don't look at, okay, what's happening at individual schools, we get stuck in, okay, the county's doing great. These are individual schools. So for one school, we have this really large decline between 41 and 27, but it started going from 41 to 23 and has then been going upwards over the last 3 years. The pattern for the second county is 28 to 14, 14 and 11. The pattern for the third is 20 to 12, and so on. And then there's one that is actually going upwards. So if our prevention approach would be at the county level, we would only be using county level numbers. We wouldn't see this massive variation that is between school communities within the same county. This is why local data is so important. We can prioritize our work in prevention by truly having access to local data, as opposed to just looking at averages and some means. But that tends to be a way more common approach. General surveying, and our kids are surveyed to death in our schools. General surveying only yields these kinds of information, and usually not even at the county, but usually district or state level. So, to close, let me just go over a few things with regards to places that have done well in this work and what tends to need to be in place and what is needed in places where it isn't going so well. So in implementation in different places, the common challenges are very oftentimes that steps 1 and 2 are not implemented well. Steps 1 and 2 are the coalition put together and built well and funded coalition. Oftentimes people run into data collection. And so what happens with that, you collect a lot of data and then you go back to the community and there's nobody on the receiving end. There's nobody to work with. You know. Coalitions need to be funded and they need to be nurtured. Secondly, at the onset, organizational levels are often poorly defined. So in bigger places, this means that if there isn't a clear line of communication and command between, let's say, county and schools or municipalities and schools, that turns often out to be quite the challenge. People won't share the data, they feel protective of their own school, they don't want others to know, and things of this nature. There's oftentimes a lack of communication and unclear authority between the levels. So sometimes people in education, they don't trust the people that work in health. People that trust in health don't trust the people that work in housing, and so on and so forth. This is what we have to tackle beforehand. Inadequate resources per the number of participating local communities. So Seward is large enough or small enough or has the adequate size for a really effective local coalition. Now let's say that you would have the same size local coalition, but you would have 15 schools. That would be pretty difficult to focus any meaningful work within each of the 15 communities. So what this means is that we have to sort of reflect the size of the community by the work that we're trying to do. Hiring of external professionals to lead local community implementation. This is almost a fatal flaw that we should never do. Always work with local people. Hire local people to lead the coalition because they are the ones that we all know and know everything about the trade. Inadequate funding of key personnel. Now, as you probably know, in public health, there's a massive reliance on short-term funding for most people. So most people that work in public health, such as in prevention, they may be juggling 15 different grants. How much work can I do in primary prevention up to local level if I'm trying to juggle 15 different grants at the same time? Very little, of course. So this, basically, the focus should be, we need to have an adequately funded body of people and within the local community to do this well. Of course, if we don't have a local coalition, then that's really, really hard to work with. Not training and educating people involved. People that work locally need to understand the model. They need to have adequate training and so on. And not matching risk and protective factors with survey measures and outcomes. So in other words, the survey is very comprehensive. You know, it has like 400 variables, which is almost unheard of with studies of this kind. But they're all geared towards community level implementation. Now, if I work with that, I will make decisions about what I need to do in my community, which means that I will have some measurement for what I'm trying to do. Now, what if I don't have measures about the things that I want to do? Then I will have no connection to the problem that I'm trying to tackle and the data that I'm trying to work with. And this happens. This does happen, you know. We've had data come through that has nothing to do with, for example, tertiary prevention or secondary prevention, and then people decide to spend all their intervention money on needle exchange programs. I mean, needle exchange programs are probably good for what they're worth when they're needed, but that's not what we're tracking. So if you're not putting the two together, we have no idea what kind of progress we're making. And short implementation cycles. This has a lot to do with the nature of the funding lines. You know, we may have a funding line for 1 year or 2 years, and we, you know, get going and start the work, and then the money dries up, and everybody just runs away and start doing other things. That unfortunately still happens. So that's pretty much it. Thank you.
So we've got a little less time than I would have loved. I'm going to go back to the 10 steps. Just in 30 seconds, I'm going to tell you where the Seward prevention and UP60 is right now in these steps and give you a little background before you guys ask any questions. So we are at step 5 right now, 5 and 6. Right now, what we're trying to do tonight is step 5, enhancing community participation and engagement. The purpose of this night is to help you guys understand what the model is and the fact that we've already begun our important work. But we need everyone to join in if we're going to be effective at community level change. And then dissemination of findings. So we've done step 1, local coalition. The Seward Prevention Coalition currently has 104 members. We're a 501c3. We meet every month. Our next meeting is in 2 days on Thursday. It's from 12 to 1:30 at the community library. It happens the fourth Thursday of every month. Coalition building, as you can see, is part of this yearly process. Any of you and all of you guys are invited to be part of it. Many of you already are. Local funding, we just secured, last month, 10-year funding from the CDC. We got the Drug-Free Communities grant. So we have 10 years of sustainable funding for this U360 program. We did our first dad election last January. This little doodad that I made here is our data. You can see on the top of the inside next to the star, we surveyed 94% of 10th graders at Seward High School. So we got a really high take rate. That's Seward-specific data. Those are our kids. After this presentation in the next weeks to come, I'm going to be doing more specific data presentations for cohorts, like of parent groups. I want to do parents that have kids between 0 and 4, parents of kindergarten through second graders, 3 through 5th, middle school parents, high school parents. I'm also doing a guided dissemination for City Council on the 27th of next month, and I'll do as many for anyone who wants to ask whenever. I'll go to Resart and we'll just sit there. But anyway, so that's sort of where we are in this process. Hopefully a lot of you are here because you're already on my email list. If you're not, my business card is also on the table. And U360 is what we call our implementation of these steps in the Icelandic prevention model in Seward. Right now, a lot of my job has become sort of a community facilitator, or clearinghouse for all the things youth in the community. Enhancing access, removing barriers to things that we already have. Seward has a lot of strengths. We have a lot of good things going on. We have a ton of people who are supporting youth and families in a ton of different ways. Right now, I'm using funds and resources in my time to make those connections and make sure we're not siloed, right? And that it's like, why aren't we getting more kids to engage with this? Why aren't we getting families to do this, value this? So anyway, so now, for the few minutes left, I just wanted to give you a little background in case you came here hoping to learn what U360 is. And then finally, before I jump off the mic and let you guys ask questions if you have them, this is a parent survey that we need as many parents as we can possibly get to take this QR code that's on your table. It's not directly related to this conversation, so I'm going to go to questions, but please don't take a picture of it first. Just look at open your camera, look at it, and then I'll ask you to open a link. Okay. All right, so discussion, questions, thoughts? Go ahead.
Quick question, Dr. Kristjansson. And before I ask the question, I want to just practice a little bit because drugs are basically medicines, right? They treat conditions. And for example, like marijuana can treat anxiety, they treat sleep disorders, it can treat chronic pain. Opioids, like fentanyl, can treat chronic pain from autoimmune diseases or motor vehicle accidents. Cigarettes, which are a stimulant, can treat ADHD. So, we have this view of like, this person's an addict or they have oppositional defiance or things like that. But I feel like, because this can be a potentially medical issue, and diagnosing like any underlying condition that they're self-medicating is important. So I was wondering where in your community picture the medical community fits in, so that they can get these early diagnoses, so they're not treating themselves, with cigarettes because they have underlying EDD, which is undiagnosed.
Well, our view in this theoretical idea is that you are still working at the population level, so the delayed onset still stands as a much more viable approach to children and youth. Now, if the question is, and I guess that's the context of your preamble, so to speak, is that you have kids that are risky prone, and therefore they may be prone to self-medicating through using drugs. If that is still debatable whether that's correct or not. But okay, let's say that that is correct. Then obviously we would want our community to interact much quicker than we are currently doing with our kids. So upstream prevention in this respect would be early diagnosis and therefore early intervention of any kind, if that is what you're asking.
Yeah. Did you have that in Iceland? That was my question. Like, did you have that piece in your
I really don't think so, to be honest with you. I do not think that our medical intervention system, and certainly not our mental health system, is nearly where it needs to be. And it's unfortunate, and it's similar to many other places. Especially the mental health system is lagging far behind needs compared to what it needs to be. But, if we're working at the population level, we really shouldn't see a great level of change in terms of individual need over time. I mean, what would dictate that much more kids are prone to be using drugs from one time to another in the form of self-medication? That would be an odd thing. But we need obviously our background and community to be much quicker on the trigger when it comes to this kind of support. I totally agree with that. Now, whether I can agree with the fact that kids at the age of 15 are treating anxiety with cannabis, no, I cannot. I would not agree with that. But, you know, it's a question of being upstream or downstream. Do we want to work upstream? And if we are wanting to work upstream, then we need obviously to start these services way earlier than we are doing now. And I think that's kind of the universal answer, to be honest. Okay? Any other?
Well, I'd like to add that we have, mental health and physical health professionals that are part of the coalition. And when it comes to capacity building, getting those seats at the table, we want people from all corners of the community, however you support youth and families in Seward, to be, part of this and what we're doing.
Working in the medical field, I have noticed that there are children that are not receiving the benefits of screening for their mental health conditions. And it's good to hear that we do, and I know some of the people that who work here in the schools, because those are very, very important, like markers also of what these children get into because of different traumas at home. And they don't have the support system at home. They don't have the protective factor of a counselor or a teacher that's willing to listen to them versus the curriculum. And that's very, very important. I think that's really a significant part of prevention as well.
Yeah, there is quite a bit of literature coming out to show that anxiety, particularly among girls, is on a steep rise and has been for a while. There's all kinds of theories about, social media and this constant pressure of that demand that is much more in your face now than it ever has been before. That's still a theory. Some people say, no, it's not that. It's just the nature that we have to learn more to interact with these mediums, and we're not there yet, and so on. I really don't know, but I guess what I do know is the prevalence studies show that mental health is, or mental health problems are becoming much more prevalent in youth. That's definitely true. My question from a primary prevention point of view would be, okay, are we going to treatment our way out of that problem, or are we going to build the base for the problem not to occur in the first place? That is basically my question, if that is at all possible. Any more? All crystal clear? Well, if not, we're here, so thank you all. Yeah, appreciate that.
Okay. It's a take.